Good morning, everyone. Thank you so much for joining us today. My name is Victoria Strang, and I am the Community Impact Director of the American Heart Association in Southern New England. We are thrilled that you have joined us today. Thanks to our generous sponsor, Tufts Health Plan, we are able to come together for an educational and powerful digital conversation on the importance of blood pressure management in the Latinx community. The American Heart Association is working with researchers, medical experts, community leaders, and more to examine social determinants of health and work to improve health equity. Our top priority is the health and well-being of all individuals and their families, both locally and across the globe. We want to keep you informed with trusted, science-based information and provide our communities with support and resources available through the AHA. Today, we will be discussing the importance of blood pressure management. Nearly half of American adults have high blood pressure, yet many don't even know that they have it. Hypertension puts you at risk for heart disease and stroke, which are the leading causes of death in the United States. In 2018, nearly 500,000 deaths in the United States included hypertension as a primary or contributing cause. Hypertension is known as the silent killer because it often has no obvious symptoms. The best way to protect yourself is by being aware of the risks and making changes that matter. Today, we are specifically focusing on hypertension in the Latinx and Hispanic community, where high blood pressure is often more common and can go untreated. High rates of hypertension amongst Hispanic and Latinx communities can be attributed to a number of social determinants, including access to healthcare, affordable food, lack of space for physical exercise, walking and biking paths, inability to attain health insurance, language barriers, and many more. The ongoing COVID-19 pandemic has further emphasized the need for increased management of chronic conditions, as we know that those with hypertension are at increased risk when contracting COVID-19. In light of the pandemic, the American Heart Association is working with clinicians and community organizations to establish self-measured blood pressure programs, also known as SMBP. These programs not only assist physicians to monitor the health of patients at home, but help individual patients take control of their own health. Thanks to a generous sponsorship from Tufts Health Plan, the American Heart Association of Southern New England will begin a new self-measured blood pressure initiative and increase hypertension education in the Latinx and Hispanic community of Central Falls, Rhode Island. Our hope is to use this webinar as an educational opportunity, as well as provide some practical ways that individuals, clinics, and community organizations can work to address high blood pressure. We have several wonderful speakers joining us this morning, including Dr. Jessica Rubenstein from Tufts Health Plan, Robin Hall from LISC, Alison Smith from the American Heart Association and American Medical Association, and Dr. America Foster from Blackstone Valley Community Healthcare. Today, we will outline the current landscape of health in Central Falls, the American Heart Association's work on hypertension through the M.A.P framework and Target BP, and the introduction of our first SMBP program with Blackstone Valley Health Center. Before we begin, we also hope to hear from you. Throughout the conversation, we invite you to submit questions to the chat box. Our speakers today will respond to any questions in the chat box, and if we have any extra time at the end, we will also open it up for questions. To start us off, I want to introduce Dr. Jessica Rubenstein, Interim Chief Medical Officer of Public Plans from Tufts Health Plan. Welcome, Dr. Rubenstein.
Let me start again. Thank you, Victoria. Hello, everyone. Tufts Health Plan is excited to be here today to team with the American Heart Association, Local Initiative Support Corporations, or LISC, and the Blackstone Valley Health Center to bring blood pressure cuffs into the homes of the health center's patients. The opportunity for patients to self-measure their blood pressure will allow their healthcare providers to monitor their patients and adjust medications without the need for additional visits to the health center. Next slide. Controlling blood pressure in the predominantly Latinx populations of Central Falls and Pawtucket is even more important now during the COVID-19 pandemic. First, per the Rhode Island Department of Public Health, Latinx adults have a high rate of obesity, higher than their white counterparts. Obesity is a common cause of high blood pressure. Second, high blood pressure is common in Rhode Island, and per the Rhode Island Department of Public Health, 1 in 3 adults has been diagnosed with elevated blood pressure. Elevated blood pressure is a common cause of heart disease, which in turn, as Victoria said, is a risk factor for severe COVID-19 infection. Lastly, both Central Falls and Pawtucket have been hard hit by the coronavirus. Per the Rhode Island Department of Health, infections rates are 4 times higher in Hispanic or Latinx populations compared to the non-Hispanic white communities. In fact, Central Falls has the highest rate of coronavirus in the state, with over 8,000 per 100,000 cases, which is equivalent to 8 cases for every 100 individuals. And Pawtucket's rate is about half that. Improving blood pressure via self-measurement will hopefully decrease the severity of COVID-19 infections in these communities, as well as prevent future medical conditions such as heart disease and stroke. Next slide. Besides blood pressure control, Tufts Health Plan is committed to other projects that promote health and wellness in Central Falls. Working with the elementary schools, Tufts Health Plan is developing a childhood obesity intervention, working with a local pediatrician, increasing immunization rates, and on a more fun note, teaming with the City of Central Falls and Project Goal to invest in recreational activities, including a soccer field. Next slide. Tufts Health Rhode Island Together is a Medicaid plan sponsored by Tufts Health Plan. Enrolling in Tufts Health Rhode Island Together is an option for those that qualify for Medicaid, including Right Care, Rhody Partners, and the Medicaid expansion. We have a large and growing network of trusted providers that can deliver healthcare to you wherever you need or live in Rhode Island. Next slide. For information or enrollment in Tufts Health Rhode Island Together, you can contact HealthSource online at healthsourcerhrodeisland.com or via phone at 855-840-4774. Thank you, and now back to Victoria.
Thank you so much, Dr. Rubenstein. All those initiatives sound so wonderful. As a reminder to our guests, we are recording this webinar and we'll make it available to share after the event. And finally, if you are using social media this morning, please use the hashtags that you see on the screen, hashtag SNEHeart and at SNEHeart. Now I want to turn it over to Robin Hall, who is the Assistant Program Officer from the Local Initiative Support Corporation, to tell us more about the current state of health in Central Falls and the Pawtucket community. Welcome, Robin.
Good morning. Thanks so much for having us today. My name is Robin Hall. The Pawtucket Central Falls Health Equity Zone is excited to be here to connect with additional partners and to learn more about the programs that are being put in place. Health equity zones are place-based, community-focused collaborations working to address the health of a community, working across sectors, but also in community. There are 10 in Rhode Island, and LISC is the facilitator of the Pawtucket Central Falls Health Equity Zone. As you can see here, our collaborative is focused on policy, youth engagement, resident engagement, and substance use disorder. Next slide. I wanted to paint a little bit of a picture for you of Pawtucket and Central Falls. So there are over 91,000 residents in the two communities, And as we're talking about chronic disease and management of disease, some significant data to highlight is that 50% in each community have Medicare, Medicaid, or no health insurance. Over 40% of youth in each community are obese. 41% in Pawtucket and 68% in Central Falls speak a language other than English at home. So we have a significant minority and immigrant population. You can also see that there is poverty in each community. Next slide. A couple of other data points that track with health outcomes and the management of disease that I wanted to highlight. So the CDC has a social vulnerability index. It ranks each census tract on 15 social factors, including poverty, vehicle access, and population density. So the purpose of this tool is really to identify communities that are likely to need support before, during, or after a hazardous event, but they really also indicate those communities that are just in a vulnerable position. Two of the census tracts in Pawtucket, one in Pawtucket, one in Central Falls, are among the most vulnerable in the state, and multiple tracts are clearly vulnerable. You can see from the map slide here. Housing cost burden also indicates our ability to manage cost, stress, healthy food, medical bills, access to care. Central Falls and Pawtucket are highly cost burdened, and notably in Central Falls, over half of residents are cost burdened. So this measure really signals the environmental stresses on a family and the bandwidth to manage additional health concerns. This data will be kind of in the background of the conversation as we continue today, but I also want to point out some of the social resources and assets that are in Central Falls and Pawtucket. There are multiple youth programs that are part of our health equity zone, and they give youth a robust, engaging opportunity in terms of leadership, art, mentorship, and even directly around improved health. Another example of the assets of the community are the two cities really joined together with the private organization, many of the community partners, to develop a call center so that folks speaking multiple languages, either experiencing COVID symptoms or really not sure where to turn, can call the call center, get scheduled for a test, know that they can access someone who speaks their language, and really get some trusted community member support. Through this call center, they also get support and referrals in the need to isolate and quarantine. Our health equity zone has been in existence for into our 6th year now, so that's another resource in the community. And I know Blackstone Valley Community Health Center is on the call, but also just want to point out all that they bring to the community. And Liz helped with the early on with the facility there. They provide one-on-one resource navigation to folks. And even just this week, heard of somebody, a CHW there, a health worker there, who helped somebody access unemployment benefits due to a misunderstanding on the question. So they really are helping folks in every kind of barrier or access to needs that can make the family more stable and have better health outcomes. Next slide. As we start to look at diabetes specifically, we've talked a little bit about the prevalence of chronic disease in Rhode Island, but we generally know that the residents in Pawtucket and Central Falls experience these things in the same way. So when individuals live below the poverty level, they have significantly higher diabetes rates, and Black and minority folks have the disease onset at an earlier age. So they're really managing that disease over a longer time. With our high concentration of poverty and strong immigrant and minority population, we know diabetes and chronic disease impact our residents. One of our partners is Progreso Latino, and they're offering diabetes programming and daily engagement with individuals to work to manage disease. One just additional piece of data to note is that folks with diabetes in Rhode Island, over 50% have been concerned about where their next meal is coming from. The Health Equity Zone also did an assessment, and one of the greatest needs identified by the collaborative members was healthy food access, which we know is foundational to improved health and chronic disease management in general. Next slide. Similar with hypertension and high cholesterol, we can see the real disparity in Rhode Island overall and can extrapolate that these issues are prevalent in Pawtucket and Central Falls. Next slide. One of the things that the Health Equity Zone does is to work on engaging with the community and how to address social factors and infrastructure that impact health. We recently participated in the Health Equity Challenge, which the Department of Health helped bring together. Our partners in that project were Family Service of Rhode Island, Progresso, Care New England, and some community members, and one that really served on the team continually. Our first step in that process was to do a mini needs assessment. So we pulled from the HES data that I mentioned before, interviewed people with lived experience, and surveyed pantries in the community to see what are the options and what is the access to healthy food through a pantry. All of those things really identified healthy food access as a significant need across the community. So our pilot included delivering healthy food to some additional individuals that were experiencing diabetes. So Family Service of Rhode Island had a Be Safe Kit project they launched at the beginning of COVID. It delivers masks, shelf-stable food, and cleaning supplies. In Pawtucket and Central Falls with the HES, we were able to add fresh food to that. And then with this pilot, we made sure that that food was tailored to the diet that was needed. The pilot was a big hit. Our post-survey results showed that the kit helped manage disease. Folks enjoyed the fresh fruits and vegetables, and we're looking at next steps on how to continue that momentum and build on that success. Particularly as patients are managing disease more and more from home at this current time, we're excited to learn more about what's happening here and then to continue to partner with the organizations on the call. A significant component of this project was connecting individuals with diabetes in the design and implementation. So individuals with lived experience really helped tailor the kits to include measuring cups, placemats, the timing of the delivery, and the different kinds of ingredients to include. This project really is an example of what the HES is after, connecting with needs, working together as a collaborative to address them, and then working to build on that success. Next slide. In general, the Health Equity Zones work to improve health outcomes by taking a holistic look at individuals, community, and the potential solutions that can be driven by residents. Here's my contact information, and again, want to thank you for having us on the call today.
Thank you so much for that, Robin. You guys are doing great work in the community, and I know this was only a snapshot of that, so I appreciate you coming on. As a reminder to everyone, we will be taking questions in the chat box, both throughout the presentations and at the end if we have some extra time. Now I am happy to turn it over to Allison Smith, Program Director of Target BP with the American Heart Association and the American Medical Association. And she's going to tell us a bit more about what these organizations are doing on the clinical side to support both clinics and patients. Good morning, Allison.
Good morning. Thank you very much for the invitation to be with you. I am grateful to be here, but more importantly, I'm grateful for the work that you all are doing in Central Falls, Pawtucket, and across Rhode Island. It's really exciting to see the new work that you're doing to support patients in their successful control of hypertension. Today, I want to share a little bit of a national context for blood pressure control, give an overview of Target BP and specifically the M.A.P framework, and also share with you the resources that are available to your teams for your practice in clinic, as well as for patients and their success in self-measured blood pressure at home. If you could go to the next slide, please. So while the CDC has never met a preventable chronic condition that it likes, this illustrates that blood pressure is among its most unfavored because of the very significant role that it plays in heart attacks and strokes. As Victoria alluded to before, if all we did was focus on blood pressure control, we could prevent more than 500,000 heart attacks and strokes. And so while it's important to attend to all of these conditions, clearly there is a case to be made for a focus and investment in blood pressure specifically. So how are we doing in blood pressure control? Next slide, please. In the early 2000s, we witnessed notable improvement in blood pressure control, and that progress has leveled off in in the early 2010s. In September, Muttner et al. Released a serial cross-sectional study that showed a continued decline from what's illustrated here to levels in the low 40s, like 43% in the 2017s and 2018s. As you know, public health data trends lag, the reporting lags, but we can only worry that these control rates have actually dipped even farther during the pandemic. Next slide, please. COVID really has magnified the health disparities that we've long recognized. Patients with cardiovascular disease are more vulnerable to severe illnesses due to COVID. And notably, there are differences in cases and hospitalizations and deaths across different racial and ethnic groups. Notably, Hispanics and Latino individuals have experienced 2.8 times the case rate, 4.6 times the hospitalization rates compared to their white non-Hispanic colleagues. And that is certainly, as has been highlighted in data that's specific to your community, and I'm sure is top of mind. Next slide, please. Adding to the reasons and to the momentum for focusing on blood pressure control, you're probably aware that the U.S. Surgeon General issued a call to action recently to reinforce the need to prioritize and support patients, healthcare providers in the care that they provide, as well as the communities in which they live. Next slide, please. So I'm going to start with an overview of Target BP because we know that lowering blood pressure is the single most important thing we can do to reduce heart attacks, strokes, and deaths. Of all the physicians, nurses, pharmacists, community health workers, or medical assistants, public health workers, or administrators and others who are joining us today, we know that there are many conditions that you support patients in dealing with, but there really isn't a condition that's more deadly, that's easier or cheaper to address than blood pressure with non-invasive testing, with generic or low-cost medications, lifestyle change, and yet sort of the complexity of ambulatory clinic management and factors that influence patient access and choices make blood pressure control quite elusive. So on the next slide, please. This is just an overview of what exists under the Target BP umbrella. Target BP was launched by the AHA and the AMA in 2015 as a national call to action to address blood pressure, the silent killer. Underneath this umbrella, you'll find resources to support quality improvement, professional education, as well as annual recognition. So AHA and AMA have combined forces also inside the Washington Beltway, advocating for changes so that we are aligning what we know to be true in this hypertension guidelines and in science with the health ecosystem, ensuring that patient access and provider incentives for care are aligned with the science. So I want to touch on each of these areas briefly and then spend the remainder of the time highlighting some of the tools and resources that are available to you in your clinics and to support your patients. Next slide, please. So Target BP embraces the M.A.P framework, M.A.P, measure accurately, act rapidly, and partner with patients. This is a QI methodology, an evidence-based approach that's been published in the peer-reviewed literature to improve blood pressure control to rates greater than 70% and fewer than 6 months. Each of the phases of this framework focuses on a specific barrier to blood pressure control. So first with M, measure accurately, we focus on ensuring that every patient's blood pressure is taken correctly every time. So that starts with using validated blood pressure equipment, calibrating your equipment according to guidelines. And that might mean every 1 to 2 years if you're using oscillometric devices. That might mean every 2 to 4 weeks if you're using handheld Android devices. So the equipment has to be accurate. Similarly, we need to use the equipment with proper technique, positioning patients in a way that their back and feet are supported, their arm is supported, their bladder is empty, no one is talking in the room, they've rested for 5 minutes, the cuff is over a bare arm, etc. There are lots of dimensions to achieving an accurate blood pressure in terms of technique. And then we also want to make sure that the environment in which blood pressures are taken, if it's an in-clinic, that there is a proper setup with a supportive share, a place for an arm to rest. So, and the systems in place to ensure that we're getting representative blood pressures are also important. So that might mean repeating a blood pressure measurement to obtain a confirmatory measurement after 5 minutes of rest if the initial is elevated, using 24-hour ambulatory measurement if a patient can achieve, can gather those readings at home, or self-measured blood pressure, which we're going to talk about more today. So that's measure accurately, and it's really designed, all of those dimensions of measurement are really designed to reduce diagnostic uncertainty. That is one of the #1 causes of physicians' hesitation to diagnose or adjust treatment for patients. So we want to make sure that those measurements are accurate for every patient, every time. Moving to the A of Act Rapidly, this is really focused on rapid intensification of blood pressure treatment, often with multiple drug classes to improve control and reduce side effects, ideally using single pill combination therapy. Of note, most patients need 2 to 3 drug classes to achieve control in their regimen. We also advocate for the use of algorithms and using monthly at the most follow-up time intervals to recheck blood pressure and drive patients' blood pressure numbers into control quickly. So treatment inertia is therapeutic inertia is the main focus of the Act Rapidly phase, to try to address every cause of that and improve control. And last but certainly not least, the P, or Partner with Patients, is focused on activating patients for self-management and promoting adherence. This is also an opportunity to address the important aspects of lifestyle change. We recommend collaborative communication techniques around treatment goals and lifestyle change, and a really open communication around the things that are interfering potentially with medication adherence, including an understanding of the medication regimen, access to medications and economic barriers, and many other potential side effects that may interfere with the patient's desire to take their medications. We also really try to leverage self-measured blood pressure as a long-term monitoring and activation strategy, and we'll talk about that more a little later. On the next slide, I just wanted to briefly highlight some of the evidence base that's published behind this framework. So if you're interested in learning more about it, I'll direct you to these publications for your follow-up and reading. On the next slide, I want to move to one of the other huge resources available to you through Target BP. Every month, we offer a free webinar with professional education. Some of those events offer free CME and CE, and they touch on each of the aspects of the M.A.P framework, on team-based care, on the blood pressure scientific statement, on the hypertension guidelines. These are also available on demand and offer enduring CME credit and CE credit. So there are many clinics who use that library of resources for watch parties, for journal club focus. There are a lot of creative ways in which organizations are using those resources to enhance the knowledge and skills of their care team. We also offer success story webinars where we highlight the efforts of individual organizations and their quest for improving their control rates. And those organizations range from large academic medical centers to small federally qualified health centers and everything in between. And so those are really informative opportunities to think about like the struggles that they're having, the solutions that they found, and a great way to share learning. And then lastly, we have other programs that focus on support for participation in our annual recognition program and how to utilize and leverage our public awareness campaign resources. And I'll touch on those in a little bit. On the next slide, I just want to highlight our annual recognition program. We just concluded the 4th year of our annual recognition program, and against all odds of COVID, we were still able to maintain over 1,000 organizations submitting their data of their control rate, which is essentially a self-reported numerator and denominator of their control rate using NQF-18 specifications. And we had over 500 organizations achieve gold status, meaning they had control rates greater than 70%. we're delighted to see this progress. That mix of organizations, again, includes, I think it's from 44 different states across the country. It includes large health systems, small single practitioner clinics, and everything in between. So we're really delighted by the ongoing engagement of these organizations and invite you to participate in the future if you're able to. Next year, we're also announcing, including a new set of awards recognizing organizations for their excellence in evidence-based blood pressure activities. So there's more to come there, and invite you to learn more about that. On the next slide, I mentioned that AHA and AMA have joined forces in Washington to advocate for health policy that supports the science. And one of our recent wins is pictured here. New in January 2020, we helped ensure that CMS provided coverage for provided reimbursement providers for self-measured blood pressure, and secured 2 new CPT codes. And there's guidance for use of these codes on our website. The first code helps support a provider and a care team instructing a patient initially on how to perform self-measurement, calibrating their devices, going through the time that it takes to instruct a patient on how to use the device and record and relay that information back to the provider and the team. There's also a new code that can be used monthly for the time and effort that the provider and the care team take in reviewing that data that's relayed back and adapting the care plan accordingly. So those are 2 great new wins this year, and we're not stopping yet. On the next slide, I just also wanted to mention in June, we released a joint policy statement, which is a great synthesis of the science around self-measured blood pressure. It also outlines some of the gaps in care that we're working really hard to close. So in summary, I just want to say that Target BP offers the M.A.P QI framework, as I discussed, all of these free professional and patient education tools, the annual recognition, and our ongoing advocacy efforts. Next slide, please. So to support your efforts in the spirit of the M.A.P framework, I just want to highlight some of the resources that are available to you for your practice to adapt and employ in your clinics in ways that are most meaningful to you. On the next slide, I mentioned that measurement accuracy starts with accurate equipment. Many countries have validated device listings, which include the lists of devices that have been independently validated for clinical accuracy. The US did not have one until this past spring. The AMA launched the first US validated device listing to provide this independent assessment of devices that are validated for clinical accuracy. Since it's a brand new list, there are only 20 some odd devices on the list out of the more than 500 that are available on the US market. This is going to grow continuously, but what I encourage you to do and your patients to do is to reference this list when you're making a purchasing decision, either to replace or expand devices in your clinics, or if you're advising a patient on a device to purchase or acquire. We want to ensure that the equipment quality that is used to measure and monitor blood pressure is not another contributor to disparities in care. On the next slide, I want to highlight what we call the M Quick Start Guide, or the Measure Accurately Quick Start Guide. This is really a roadmap for improving measurement accuracy in your clinic. It starts with some assessment tools where you can assess your clinic's environment and practices. It points you to the educational resources, the webinars with CE and CME credit associated with them to enhance and refresh your knowledge and skills. And then it provides improvement tools to help monitor your progress. On the next slide, there's an example of one of the tools just to call out here. This is our infamous red graphic, the in-office measurement positioning, and it's available in English and Spanish. It's a visual reminder to staff and patients for the impact of proper positioning, and that errors in positioning can range from a 2 to 10 millimeter mercury or more difference from the patient's actual blood pressure. And as you know, that could be the difference between a diagnosis or not, treating or not, both of which errors are very dangerous to over or estimate blood pressure. On the next slide, there's another example of one of the tools to support staff skill refinement and and making sure that every blood pressure is taken accurately every time. It's an audit tool where essentially either a supervisor can observe a staff, or you can do peer-to-peer evaluation and observing if the staff member is really adhering to all the important steps in achieving a blood pressure. The 2019 AHA-BP scientific statement actually recommends that staff be trained and have their technique checked every 6 to 12 months. I'm not sure about you, but the first time I learned about how to measure blood pressure, I think, was in the first week of nursing school. And until my current role, I don't think it had been refreshed since that time. So I think this is an important opportunity for improvement across all clinics to keep our skills safe and be mindful of what small positioning errors can do in terms of its impact on accurate measurement. On the next slide, I want to highlight and shift gears to talk about some of our SMBP, or self-measured blood pressure resources. The SMBP Quick Start Guide is a curation of all of the resources available to help staff and to help patients successfully utilize and leverage the power of SMBP. And on the next slide, there's an example of one of those tools. It's a checklist for staff to use in clinic to make sure they've covered all the important aspects of setting a patient up for success in self-measuring blood pressure at home. On the next slide, there's an example of several of the things really of my favorites. The first is this training video. It's a little less than 4 minutes in length. It's an actual demonstration of a patient self-measuring her blood pressure at home. It's a great way to leverage staff time. Some clinics will have patients watch this while they go room another patient, come in and talk through and do return demonstration. And then the patient can also watch it at home, either on his or her phone or online if they have access to that, to reinforce that teaching. It's available in English and Spanish also. In the center of the slide, you'll see the positioning graphic that was designed specifically for patients, again, to remind them of the importance of proper positioning at home. It's also available in English and Spanish. And lastly, there's a recording log that helps patients and prompts them to record in an evidence-based way to get a representative blood pressure, meaning 2 in the morning readings, 2 in the evening readings, and over consecutive days, and averaging those readings to get a representative blood pressure. All of these, again, are available on our website, free to download and print. I'm going to shift gears here and just cover a few other things that may be of interest to you in my remaining minute. One is, on the next slide, is we have curated some COVID-specific resources on the Target BP website that talk a bit about telehealth. It'll direct you to all the self-measured blood pressure resources as well. And I also want to mention on the next slide, there's a new initiative that we launched this summer, which is our race and ethnicity data collection essentials. We want to ensure that data is collected accurately at the point of care so that we can measure whether or not we are achieving equitable outcomes, and it gives us the power and the focus to improve health inequities. So that's another resource that may be of interest to your organization. And on the next slide, I also wanted to I mentioned this earlier. We know that raising public awareness is an important part of achieving blood pressure control. The AHA and AMA have teamed up with the Ad Council to create a public awareness campaign. These PSA materials are available free of charge in print and in other formats. I know in Chicago, I've seen these on the sides of bus stops. I've seen them in billboards across the country. I've seen them printed and hanging in clinics. These are stories of actual survivors available in different languages, races, and ethnicities, and are designed in a way for you to use and support your patients and your community in raising awareness. On the last slide, I just want to close by saying I encourage you to visit our website. It's dripping with free resources. I encourage you to subscribe to the newsletter. Every month, we're releasing new information, announcing new events. So I would really encourage you and all of your staff colleagues to receive it. And please use these free resources. And I'd encourage your organizations to register and be part of Target BP to demonstrate your commitment to blood pressure control and work toward high control rates. Thank you very much for your time, and I will pause now and turn it back to Victoria.
Thank you, Allison. It is just so clear from your presentation that the AHA and the AMA are doing a lot, not only to support clinicians, but to really help patients take control of their health. The website that you mentioned has so many resources, and I go back to it almost daily, I think. We really see that self-measured blood pressure programs are key to this work, which is why today I'm excited to announce that Blackstone Valley Health Center in Central Falls will be home to AHA's first self-measured blood pressure program. And I want to invite on Dr. Amir.
Thank you, Victoria. Blackstone Valley Community Healthcare, we're very excited about being a part of the program. We're very excited also because we're going to be the first self-monitoring blood pressure program in the state. Next slide. This is our newest health center and is located in Central Falls. We've been up and running now for about 2 years. It's actually going to be 2 years in December. So we're very proud of the site, and we're very proud to have our patients come and see us at that site. Next slide. Just a little bit of numbers in regards to the type of control we have both in our Central Falls and our Pawtucket offices. If you look to the left of the slide, we had about 63% blood pressure control. And of course, we saw a lot of changes with the pandemic. And if you scroll down to the right side of the slide, you will see that our numbers began to drop. And there's our October numbers were at 59% control. Now with the SMBP program, we hope to get our numbers up to about 80% control in our clinics. Next slide. Our Hispanic Latino, we have identified about 650 hypertensive patients. Next slide. The male-female ratio, we have identified more female hypertensive than males. Next slide. Next slide. The age range is between about 45 to about 65. So our program, we'll start with phase 1. Next slide. And that will be our pre-implementation area. We are going to we're going to identify Latino Central Falls patients. We'll either identify them based on their numbers when they come in to actually see us at an appointment, or we'll contact them by phone. We'll select the high-risk hypertensives, and we'll provide them with the blood pressure cuff provided through the Tufts Health Plan. Next slide. Our implementation phase will be phase 2. Next slide. So we'll identify the top 20 patients that have uncontrolled blood pressures. And on day 0, we'll give them the blood pressure cuffs. At about day 14, we'll contact the patient either by telephone, or we will call them in for an appointment, or we'll do a virtual visit with them, which we do so often now during our COVID times. We'll discuss with them their blood pressure readings over the previous 14 days, and we'll give them a good structured plan as to how they can improve their blood pressure, and also lifestyle changes that would help them have better blood pressure control. We'll do the same at about day 30 and day 45, and day 60, COVID permitting, we'll have an in-person visit where we'll actually measure their blood pressure in office. And if circumstances don't allow, we'll just do a phone visit. And if at any point if the patient express a desire to discontinue, they'll return the cuffs. And for the patients that we cannot contact or the patients that are non-compliant, we'll mark them as a no-show. And if we can't get the blood pressure cuffs back, we'll also alert Tufts and the AHA in regards to that. Next slide. Phase 3 would be our post-implementation plan. And we would, at that point, evaluate what findings we've found. Hopefully we'll be successful in lowering their blood pressure, and we would definitely report those numbers to the Tufts plan. We'll find the percentage of patients that weren't in control and that they are now in control, hopefully with the program. We'll find the average systolic and diastolic reduction. We would welcome the patient feedback in regards to what their experience was in the program. And also one of the initiatives we hope to accomplish is that if patients do want to continue this lifestyle change in monitoring their blood pressure, we'll find a way to be able to get them a permanent monitor in their homes. And the outcomes would be solicited and made available to both the AHA and the Tufts Health Plan. Next slide. So these are some of the folks that will be helping us in the program. And we know that our city of Central Falls will be better controlled with their blood pressures. Next slide. And we just want to definitely thank the AHA and thank Tufts Health Plan for bringing this to our communities, because our patients will be well served. Thank you very much. Back to you, Victoria.
Thank you so much, Dr. Foster. It was great to get that overview. And I know that I'm looking forward to checking back in a couple of months and seeing how the program has progressed and how patients are liking it. So that includes the presentation portion of our webinar this morning. And now we want to hear from you. We've already gotten a few questions in the chat box, and some of our presenters have been answering them. But I do want to invite our panelists to come back on, and I'm going to ask a couple of these questions. You know, the first one I want to ask of Allison, and this is something that I have wondered myself. One of our questions was about how long it takes to train a clinician and staff to do proper BP readings. I know even myself, when I heard all the things you said, I have never gone in and had my blood pressure taken where my feet are flat on the floor, I have an empty bladder, all those things. So could you talk a little bit about that kind of training?
Sure, it's a great question. And I will say that it does depend on the experience level of the health professional that you're referring to. I think if somebody is learning it for the first time, you know, as a student, that's a sort of a different scenario, and our program materials are really designed for practicing professionals. I think one example of a resource for you is we have a webinar that's purely on measuring accurately that lasts an hour in length, and that's something that can be watched on demand. I think it provides an important context and enhances the staff person's knowledge of blood pressure measurement to understand how variable it is and what factors contribute to accuracy or inaccuracy. I think it's important for staff to understand that. We also have a 30-minute e-learning module that I just pasted the link in the chat. We released this last year, and it's a 30-minute interactive module, again, with a half an hour of CE credit and CME credit associated with it. And it's a great refresher that focuses a little bit more on the basics of technique with a less of a focus on the broader pathophysiology, which, while important, is not as focused as this module is in terms of technique. I also think it's important, as I mentioned earlier, to actually check technique and watch using the technique quick check tool as an example, that staff are taking all of those steps to ensure proper positioning for the patient. But, to your point, Victoria, it's thinking about the broader environment. Are we setting our staff up to for success? Do they have access to calibrated and validated devices? Is your exam room set up in a way that you can take a blood pressure with a patient seated in a supportive chair? Oftentimes, I don't know how many times I've had my blood pressure taken sitting on an exam table with my arms and legs dangling. There's so many possibilities for error in that regard. So I appreciate the question. And again, we're recommending that staff are trained every 6 to 12 months, and you can use any number of the tools that I mentioned to achieve that.
Great, thank you so much. It seems like there's just a ton of free resources that clinicians and providers can access. So that's good to know. We've talked a little bit about the clinical side, but I'm also hoping to turn it over to Robin and then to Dr. Foster. With the ongoing pandemic, we know a lot of people aren't accessing health services in the same way, not going to hospitals, not necessarily even picking up their prescriptions. So Robin, I was wondering if you could tell us a little bit about what's going on the ground, about how people are feeling about going into hospitals or to doctors' offices, and then maybe about the importance of doing these kind of telehealth health interventions for the community.
The shift and again, the ability and the recognition. Can you hear me okay?
It's a little fuzzy. Okay. We're always adapting.
Is that better? I think the shift that doctors have made and the healthcare providers have made to going to telehealth has been really important. We also know that that's a barrier to folks accessing all the services that are now going remote now, is just being able to have a connection that works. As you can see, that's a struggle everywhere at times. And so we've also seen some partners kind of adapting to could they have a station in their non-medical facility where people could come to use the computer so that they can interface with the doctor in a health and safe way. So it's required, additional innovation and looking at how to address new barriers. So I think that's stressful on top of all the other factors that we've talked about throughout the webinar, just, an additional challenge that people have to face in addition to just connecting with the doctor, having healthcare, all those kinds of things. So it's important. And then it's also important to recognize that there needs to be ways to make those connections or supports or help in addressing the new challenges and new barriers.
Yeah, thank you. I know the American Heart Association has really been trying to promote to people that it is safe to go out to your doctor's office. It is safe to go to the hospital, because we don't want people to delay care. We really want them to be engaged in their healthcare right now. And those are still safe places for people to go. So Dr. Foster, kind of in that vein, one of the main advantages of these self-measured blood pressure programs is that people can take control of their health at home. Is that something that Blackstone is really looking forward to doing? Do they think it's going to make a difference for people, especially now during the pandemic, who aren't necessarily coming in as regularly to the physician's office?
That is the beautiful part of the program, because although we try to encourage patients to come in and have their blood pressure taken, and we've also opened up point of care testing that the patients can come in when they feel safest, maybe earlier in the day rather than later in the day. We have the opportunity for them to come in for a point of care test and have their blood pressure checked. But the self-monitoring program would allow them to feel even better about taking charge and being in charge of their healthcare. So we are very excited to get that going. And we definitely want to meet that goal of 80% of patients that are in great control. So we're grateful for that.
Great, great. One of the things that I also want to make sure was pointed out today, Allison, you talked about so many things, but I did want to make sure that we hinted on the incentives to the clinics. So I'm hoping that you could also talk about the CPT coding and those kinds of things that clinics can take advantage of.
Sure. As I mentioned, AHA and AMA have advocated. We submitted a coverage determination to CMS to say we want providers to be reimbursed for using self-measured blood pressure to create that incentive and align it with the 2017 hypertension guidelines. And we were successful in doing so. We know when CMS and Medicare coverage occurs, oftentimes other payers follow. And so hopefully we'll see more and more of that, Medicaid coverage at the state level and other commercial plans. And we are actively talking with other payers to achieve that same type of coverage. Those two codes, and these are different from the chronic care codes that you may be familiar with. There are two codes, one to help set up a patient for success and training, calibrating their device and going over, all the steps needed to measure accurately and record and have a plan for relaying that information back, because that's where the real power of SMBP comes, is in that relay of information back. If it doesn't get back to the provider, care is not, treatment is not adjusted, therapeutic inertia persists, and we don't achieve our, blood pressure control goals. So those are really important new resources available to you. The other thing I will say is that AHA and AMA are advocating for the coverage of devices. And that is all I can say at this moment is stay tuned, subscribe to our newsletter, and be prepared to advocate in that regard, because we have hopefully a new opportunity to expand device coverage, because that's another important sort of part of the piece of the puzzle.
Great. Yeah, we're almost up with our hour, but I just want to say that what is so valuable to me as someone who works in the community on healthcare access, as well as works with clinicians, is we're talking about how to provide health equity and health access on several levels. We're talking about it on the community level, doing community education, on the patient level, making sure that patients can take control of their own health. We're also talking about how to train physicians and clinicians. And even Allison just mentioned on an advocacy standpoint, how can we ensure that all of these activities and health promotions are really going into the community and really that the clinics are being reimbursed for all the great work that we're doing. So there's a lot going on here. And I just want to say that I am so thankful to everyone who presented on this call. It has been a big overview for 1 hour. We hit a lot of topics, but I am so excited that Rhode Island is going to be starting a self-measured blood pressure program. I'm really excited to hear from Blackstone Valley about how these things go. And I am so thankful to Tufts Health Plan, to Dr. Rubenstein, and to others for really making this program possible. Hypertension is such an important topic, and one that really impacts a lot of us in Rhode Island, as we've seen from the presentation today. So I hope that this is just the beginning of a larger conversation, and that we can all continue to work together to make sure that these programs spread throughout the state, that we're supporting people in the ways that they need support. And I look forward to continuing this conversation in the months and years to come. So thank you to everyone on this call, and thank you to all our panelists for joining us this morning.